Many thanks, ladies and gentlemen. It's wonderful to be here with you at the Next Generation Summit. I'd also like to particularly thank the organisers and Phil, who've been instrumental in us coming here. My name is Hutan Ashrafian. I'm the Chief Medical Officer of Harbinger Health. And what I want to talk to you today is something that has become very close to my heart over the past 3 years. So we are at a precipice. 10 million people a year are dying from cancer. Approximately 18 million people a year are being diagnosed with cancer annually, and this, by the year 2040, is likely to go up to 30 million. There is a classical paradigm. Most of our cancer care is focused on diagnosis and treatment of symptomatic, typically late-stage individuals. As a result, on one hand, we have an issue of a preponderance towards late-stage diagnosis, which is a calamity. But at the same time, we do have a screening paradigm. But that screening paradigm, which is based on the good concepts of Wilson and Younger, still, to some extent, are limiting. The reality of cancer is that increasingly we can detect it at much earlier stages. And actually, rather than just considering cancer in its early stages, we need to consider it in its nascent origins, at the point where it originates, the area that I'd like to call pre-disease. Now, in the metabolic world, this is a well-established concept. Individuals with pre-diabetes and pre-hypertension are regularly treated and considered for management, although we don't have such a strong paradigm in the cancer continuum of care. And the nature of what Harbinger wants to offer is a solution to that space. Harbinger is focused on solving the challenges associated with cancer screening, but screening in the wider sense of the term. So there are 3 domains that we need to achieve for society to be able to address the cancer outcomes that I mentioned earlier. Those include performance, focusing on that high early stage diagnosis, but actually with a PPV and a predictive value that takes us not only in the earlier stages, but maybe highlights the pre-disease areas. 2, the clinical informativeness of any test, so that clinicians are empowered on what to look for and where to look for them. Because as we've already seen today, sometimes there can be too much noise for them. And the signals ratio of false positives can be a detrimental factor. And 3, the reality, and that is access. Social determinants of care remain a major driver for cancer outcomes. And having a test that is expensive or not accessible is sometimes exhaustive and not useful for global patient outcomes. And that is what we want to address. Our scientific background comes from the novel finding that a cancer that grows and invades and has angiogenesis and guides a local regional immune system actually has many metaphorical but actually direct biological comparisons with cancer. A blastocyst that enters the endometrium for implantation carries many, many signals of invasion that can be comparable to that of a cancer. And interestingly, we decided to look at this to identify that the methylome of both the CPG islands and their EXE regions can mimic what we find in the blastocyst and the implantation of an embryo. So that understanding the methylome of an embryo can actually give us an understanding of many different cancer types, or an MCED cancer diagnostic. This is a diagram just highlighting how the DNA methylome of colorectal cancer can be mimicked to some extent, just visually, and I can do it for you mathematically too, on a placenta or a growing embryo. And so this is important for us. So based on this technology, we've developed a proprietary diagnostic capability for screening that not only looks at cancers at stage 1 to 4, but importantly can give us a vision into pre-malignant lesions. These are 4 examples just to show you that For multiple myeloma, we've been able to look at MGUS. For breast cancer, we've been able to look at DCIS. For esophageal cancer, we've looked at Barrett's esophagus. And for colorectal cancer, we've been looking at adenoma, highlighting that for each of these cancers, we are able to look at their precancerous lesions based on their methylome and their methylome load at the CpG islands and EXEs. Okay, so that is the proof of concept, but what are some results? We took 1,000 samples from a wide variety of cancers in a clinical cohort, and this identified our ability to be able to characterize and diagnose stage 1, stage 2, stage 3, stage 4 cancers with a relatively strong sensitivity across the board. The specificity across all of these as a threshold was 95%, and we're working on actually increasing this to even higher levels. Our proprietary system looks not only at the bisulfide sequencing of CpG islands using a ML detection tuning strategy, but also augmenting our test in a way that we feel would be accessible for individuals across society, across socioeconomic groups, and across ethnicities and ages. Our approach to implement our test focuses on a dual domain, what we call tiers of testing. We have a first tier of testing, and that is focused on a low-cost target, more than 99% NPV test that is of a high accuracy and one that can exclude cancers. So it is the first tier of our screening test, and as a result, following that low-cost test, if there is a positive signal, we move on to our second tier. This double-tier approach then allows us to focus on that second-tier group, not only to give them a diagnostic accuracy, but also a TOO, so that in a reflex setting, we will be able to offer a very significant increase in terms of PPV, but also in terms of TOO, and supporting clinicians when they really need it the most. Our approach to validate our idea has been one of a 10,000 patient study that we are expanding in 3 parts. One is a case control design. 2 is it's an adaptive study. There is a longitudinal arm to it, and is one to get our diagnostic test to an LDT by next year. The aim of our studies with our friends at Sarah Cannon is, 1, to confirm the performance accuracy of our test so that we can objectively demonstrate in the peer-reviewed literature and to our clinical colleagues exactly how strong we can detect cancers across the board. 2, to really highlight the fact of our 2-tier approach or our multi-tier approach can really offer us a capability of having that pan-society, low-cost initial high NPV test that then follows on with a highly accurate second test. Lastly, this is to really boost our capability to have our LDT ready by next year so we can come to next year's conference and show you the results as soon as possible. You might say, how do we do this? What is our strategy to really move this forward? Because that needs scalability. And as we're talking about whole society level detection, what is our scaling plan? Well, initially, both our Tier 1 and Tier 2 will be done in-house at our laboratories in Boston. And as I suggested, the first tier is to exclude cancers, and the second tier is to then confirm and offer TOO. But actually, then we plan to decentralize very quickly. So by the 2028, we plan to have kits based on an NGS platform that we can do our TOO, but yet do our Tier 2 or our high diagnostic accuracy positive test in our labs. But then by 2030 and onwards, we want to have the whole thing to be decentralized and allowing both our partners with their kits and other labs, including our own, to be able to do this in-house. This is the team. We're a growing company. We've been able to really push some of the boundaries that we thought were unpushable many months ago. The ability to really think outside the box, particularly based on this novel idea of the blastocyst growing in an endometrium, has really given us novel insights. And it's been a pleasure to discuss these results with you today.